Presidential theme of orthopedic excellence through technology, I would be talking in favor of minimally invasive surgery. As you know, the minimally invasive, some people equate it to minimally aggressive surgery also. And what we mean actually is it helps to avoid an open surgical procedure by less traumatization. So from this, we try to accommodate all our indications in this wherever possible. So the traditional surgery, it has been many, many years, and then we have a lot of literature showing a lot of complications, right from scarring post-operative, tethering, instability because of wide laminectomies, pain syndrome, subsidence, pseudarthrosis, and then approach-related problems. So that is why people want to have something new and more safer approaches. And even patients are not willing to undergo these major surgeries. And hence, if we see the common back problems like what we treat is a prolapsed disc, then treating such large disc with a large open surgery or with a small minimally invasive approach is the today's talk. This is a 28 years old female. She had been treated conservatively for 3 months. And when they came to us, they said she is going to get married in the next 15 days. So you give us this treatment, because by the time her left leg had become numb, she could not even stand for 10 minutes. So everybody was worried whether she would be able to undergo marriage, and they wanted relief from it. And then she has undergone this surgery. You can see the scar, what is there. And so much big disc has been removed, and everything has been done under local anesthesia. And as planned, she has married now after 2 weeks of surgery. So this is the beauty of minimally invasive surgery. If you would have gone for traditional open surgery, maybe they had to change their plans, because she was treated conservatively already for 3 months before, and then just with 15 days, we had only option of doing minimally invasive surgery. So with the technological advantage, in 70s, we used to do conventional spine surgeries. As microscope came in, we started doing microscopic surgery, where the field and clarity improved, and with new technology coming in with endoscopic, now we can do same things, producing same results, using small endoscopes of variable instrument dimensions like 3.1 millimeters or 4 millimeters. And it has got a wide angle so that inside the field what you visualize is similar. For example, I am giving you the same surgery done by 2 different surgeons, one by us endoscopic interlaminar surgery, posterior, and second is microdiscectomy. And you see the difference. 4-day post-operatively, the posterior muscle damage which has been done by microdiscectomy approach and by endoscopic interlaminar approach done through 4.1 millimeter channel. And this is a 12 months post-operatively, the MRI of the same patient. You can see even microdiscectomy causes major fibrosis as compared to what tissue preservation has been done, and the result is similar. You can see good decompression, patient is free of symptoms, and these are the results what you can achieve with the technology. Take another modality like spine fracture. This is a young patient, spine fracture, bedridden, and she wants to have good spine. So she was treated by percutaneous pedicular fixation, and these are immediate post-operative pictures you can see. And also another example of having multiple adjacent fractures you can use with the similar percutaneous approaches. Another common indication, spondylolisthesis, treated by percutaneous method, percutaneous TLIF, less operative time, minimal tissue damage, decreased infection, less pain, and early mobilization. You can see the scars, muscle damage is less. And considering malignancy, this is an old lady, has already undergone chemotherapy, radiation, excision surgery for her abdominal CA, and she developed a pathological fracture. At this point, you cannot go anteroposteriorly, and just she is treated by minimally invasive surgery of vesselplasty. This is a 16 months follow-up, everything done under local anesthesia. So same day patient goes home without any major scar, and this is the result of technology what you can achieve in an old lady. So until and unless subjecting her to a major anteroposterior surgery, this is done under local anesthesia, and she has survived for 16 months post-operatively. I agree that learning curve for minimal invasive surgery is long. We need to understand normal and endoscopic anatomy and need adequate expertise. So see one, do one, teach one attitude does not work in minimally invasive spine surgery. So, and then as you saw, the newer technologies will reduce the radiation like in navigation. This is an endoscopic clip of another young IT person where we are doing endoscopic discectomy under local anesthesia. And you can see large chunk of disc is removed and you can see nice thecal sac pulsating with the respiratory movements. So smaller incision and traumatization, selective decompression, less hospital stay, early mobilization, fast rehabilitation with improved outcomes. So this is a win-win situation for patients as
Dr.
well as
Bhave,
for surgeons.
Dr. Bhave, please sum
Last
up.
slide, last 2 slides, sir. Yesterday in this auditorium only, we listened to Dr. Diveshu Ganatra. He told us that he knows only 2 classes of people. Those who know about their disabilities and those who don't know about their disabilities. I would like to modify a little better. I would like to add, I feel we have 2 types of surgeons who know about their abilities to perform minimally invasive spine surgeries and those who don't know their abilities. So same is the case with my colleague Abhay. He does not know about his abilities to perform MISS. Once he knows about it, he will shift to MISS, I am very sure, and benefit his patients. And there would be no debate henceforward in next incoming MOA cons or spine surgeries. So
Thank
to
you,
summarize,
Dr. Bhave. Thank you. We got a
Yes,
summary.
yes, Abhay,
We got
come
a
on.
summary. Thank you.
to conclude, yeah, this is the last slide. MISS has replaced most of the common indications, common surgeries, what we do as a spine surgeon. We still have limitations, but technology will give us more and more indication in future. Thank you very much.
Thank you, Dr.